Good evening. As president of the BVOT, it's a pleasure to welcome you on this instructional course lecture. It's the second instructional course lecture out of 4, and it's still framing within the Orthopaedica Belgica Conference 2020. The Orthopaedica Belgica Conference is a national conference with a strong input of all subgroups, and we consider these subgroups as very important cornerstones of our scientific organizations. The ICL of this evening is organized by the Belgian Hand Group, a national and a very important subgroup counting 171 members. So thanks, Belgian Hand Group, for your input today. We have 6 speakers, and we cover topics as wrist pain in gymnasts, cyclists, and tennis players, and in other recreational athletes. The session is divided in 2. We have 6 speakers. After the first 2 speakers, we will have time for discussion. There is a question button. Please do use that question button. It's nice for all speakers to have some input. So don't be shy and please forward your questions, and these will be selected by the moderators and they will be forwarded to the speakers. The moderators of today are Arnold Kramer, who is an orthopedic surgeon and hand surgeon in our department, and that's in the AZ Delta in Roeselare. He's a member of the Belgian Hand Group as well. And the second moderator is Joris Durings. He's a hand surgeon in Ziekenhuis Oost-Limburg in Zoll. He's a board member of the Belgian Hand Group, and he's the FESH delegate for the Belgian Hand Group. Before kicking off, I would like to thank all sponsors. We know that without support of the sponsors, these kind of organizations would not be possible. And always my pleasure to pass the screen to Arne, who will lead the session together with Joris, and Arne de Kramer will introduce the first speaker.
Dear colleagues, dear all, welcome in this session about hand and wrist problems in athletes. I'm happy to introduce you Miriam Opdeen as first speaker. She's a plastic surgeon at UMC Hospital in Amsterdam with a specific interest in sport lesions and treatment of spasticity in upper limb of children. She's also known as a teacher for plastic reconstructive and hand surgery, and we are happy she could join us in this session, Miriam, straight from the Netherlands. Far away nowadays. Your title, How to Solve Wrist Pain in Gymnasts. It's up to you.
Thank you so much for this nice introduction, and good evening, ladies and gentlemen. I would like to thank the organizing committee for inviting me here. And in the next 10 minutes, I will tell you something about the ways we try to solve wrist pain in gymnasts. I have no financial disclosures, and I would like to thank Professor Mario Maas, a radiologist in our hospital, and Laura Cox, who has written her thesis about this subject, and I used some of her images. In every sport, you will encounter specific injuries, and we'll probably talk in this session a little bit about the other injuries, but I will focus now on the injuries of the gymnast, which is mainly the gymnast wrist, dorsal wrist impingement, and I will tell you something about carpal bossing. As in every patient that we see, the history and physical examination are very, very important. The specific things when you deal with elite athletes is, first of all, the relationship between the complaints and the sports activity. I often ask these children, and I do a lot of children in the gymnast group, would you be here if you were not an elite athlete? It does give you a little bit of an impression of the kind of complaints that they have and how much it is related to their sports. And the other very specific thing is that you need to have an idea of the sport calendar. It's sometimes very important to discuss if we need a short time solution because there's a very important match coming on, or if you can take some time to work on a longer lasting solution so that they'll be ready for the important matches that may be in spring or summer next year. And then in the physical examination, I'll come back to you on that point. The pain localization is extremely important because, as you know, in the small portion of the wrist, which is only a small portion of the human body, there's so many structures very, very near to each other that can all cause the pain. It's very important to differentiate between these localizations. When we talk about radial-sided wrist pain, we have the whole range of differential diagnosis that you probably know. And I will focus mostly, as I said, on the carpal boss, the dorsal wrist impingement, and the gymnast wrist. When we go to the other side of the wrist, of course, we have the ulnar-sided wrist pain, which we also see in the gymnast, the TFC problems, especially the meniscus homolog synovitis, which is just distal to the styloid process of the ulna, and the ECU tendinitis. But I won't focus too much on that in this presentation. So when we go back to the dorsal radial-sided wrist pain, as you can see, the wrist is really under a lot of pressure in the gymnasts. And as you can see on the left side, this girl has really a hyperextension in her wrist, and they do that from a very, very young age. It's also a sport that is being practiced in the Netherlands a lot of times. We have about 175,000 people doing gymnasts, and that varies between 2 to 30 hours a week. And these young children, about 9, 10, 11 years old, sometimes practice their sports 25 to 30 hours a week. And a lot of these young gymnasts do report wrist pain. We don't know exactly what the prevalence is of epiphyseal problems of the radius. So when we go to the first diagnosis, the carpal bossing, which of course is also often misdiagnosed with a ganglion, you all know this problem. It's a swelling, bony swelling at the CMC2, CMC3 joint, and it can cause extension blockage in the wrist, and it can cause irritation of the extensor tendons. And this is treated just the way you would treat any other patient. Then the dorsal wrist impingement is more specific for gymnasts. Because of the hyperextension, they tend to get an irritation or synovitis of the dorsal wrist capsula. And this dorsal wrist capsula needs to be able to ply and then extend again in the movement of the wrist. And if you put a hyperextension force on the wrist for many times a day and for a lot of days in the week, you can get irritation of the capsula. It causes thickening of the capsula, and it causes impingement. And I explain it to the parents and the children because it's like this little toy that you have, and I show it on the skin of the hand, on the dorsum of the hand, that if you extend your wrist, it will ply, and then if you flex it again, it will extend. And a capsula that is thickened will not follow these movements, and it can get impinged between the carpal bones and the distal radius. The treatment can be, of course, either a brace or an injection with corticosteroids sometimes. And we've also developed these special braces that are called tiger pawns. And what you can do is that you can switch this foam, which is on the volar side, and it allows you to put pressure on the wrist without having a full hyperextension of the wrist. Then what we usually call in literature the gymnast wrist, which is usually a problem of the radial epiphysis. And what you can see is in the normal wrist, in a young child, you will see this small line of the epiphysis, which is white because it contains fluid. And this is a normal epiphysis. It has a couple of layers. And if you do an MRI, which is actually probably the best way to diagnose this problem, you would see these kind of images. But then if you have, and I We'll show this again here with the different layers with black bone and then the white zone, which is the epiphysis. In a gymnast wrist, on a normal X-ray, you can see these images. And you see at the arrow, there's a widening of the epiphysis. There's also some blurring of the bone around. Sometimes you can see a very wide cortex around that area. And on the lateral image, you can see this widening even better. And if you make an MRI, you will see these kind of images with a lot of edema here, very irregular, and sometimes a lot of bone marrow edema. But the problem is, and that's the thesis of Laura Cox, is that we see these abnormalities in about 70% of the patients with pain in their wrist doing gymnasts. But we also see it in 50% of the asymptomatic patients and even in 33% of healthy young children, which makes it very difficult to say when is this pathological. And that's why I come back to my first remark about the physical examination. It's very, very important to really pinpoint out the painful spot on the wrist. And we say now that if they have pain exactly in the area of the epiphyseal disc and you see these abnormalities in the X-ray and on the MRI, we call it a gymnast wrist. And you can see here that the other way that you can find differences is this metaphyseal bone marrow edema, which is very often associated with problems of the epiphyseal disc. But also this is something that we found in normal controls and asymptomatic gymnasts. The treatment of this problem is usually by casting. The fact that you just keep the wrist straight and you make sure that they put no pressure on the epiphyseal disc anymore is, in my view, enough to treat this problem. We're still looking for the correct amount of time that you should keep them in a cast. We usually start now with, depending on the severity of the symptoms, 4 to 6 weeks. And then we do a physical examination again, and very often we repeat the X-ray. We're now using these casts, but I'm hoping to go to something more modern that would be more comfortable for the youngsters to wear. And you have to realize that these are elite athletes. So they will use any freedom that you'll give them to still be doing their sports. So you have to be very strict with them, really explain to them that if they keep a good rest in the brace for 6 weeks, it will probably go away. If not, they always risk having it longer. And we have a nice saying in Holland, which says, zachte heelmeesters maken stinkende wonden. It translates in English to gentle healers make stinking wounds. And apparently there's a French version as well. Les guérisseurs doux font des blessures malodorantes. And that's not what you want. This was a short presentation, and I do hope I was getting you a little bit from this state to this state with some lights to the threes. And I would thank you very much for your attention.
Thank you, Miriam, for this nice overview about the specific pathology in a specific group of athletes. Thank you for that. For me, it's not so difficult to introduce the next speaker, Joris Durings. He's a hand surgeon at the Zoll Hospital in Genk. Why? Because we were trained together at the University of Leuven under the wings of Professor Luc de Smet. Joris has also a specific interest in science and certainly about the CMC joint. So his talk today is about atraumatic dorsal wrist pain in the young athletes. Joris, the floor is yours.
So my talk will be about atraumatic dorsal wrist pain in the young athletes. Miriam has already told us that gymnasts rely a lot on their wrists and they have to do a lot of wrist extension movements. But this is not only in gymnastics. In many sports like doing push-ups, cycling, yoga, Pilates, weightlifting, all these athletes have to rely on good wrist extension. But unfortunately, in several of these athletes, this repetitive wrist extension will cause dorsal wrist pain. And we will have a further look into this problem. So what happens exactly in the wrist when you give it an extension motion? When we look to the motion of the carpal bones, we see that the scaphoid and the lunate, when the wrist is hyperextended, they do not extend to the same amount. So actually, when compared to the neutral position, in the hyperextension, the scaphoid will extend 20 degrees more than the lunate. And of course, this will put a lot of stress on the scapholunate ligament that has to keep these two bones together. The second thing that happens between the scaphoid and the lunate is that with wrist extension, the scaphoid will supinate and the lunate will pronate. And that's another motion that gives an actual separation of both bones with wrist extension, which again gives an excessive loading on the scapholunate ligament. So it seems that with wrist hyperextension, the scapholunate ligament has to wear most of the loads. When we look to patients that have dorsal wrist pain with wrist extension, what can be then the cause of the pain? This was looked at in an MRI study 3 years ago, and they found that in those specific subgroup of patients, in 76% of them, there was an occult dorsal ganglion cyst. An MRI, then you will see on the T2 images a cyst that lies on top of the scapholunate ligament. And typically, this cyst is small, only 1 to 2 millimeters high. It's typical deep of the dorsal wrist capsule and the extensor tendons. In another study, again, in patients that had dorsal wrist pain with wrist extension, they did not do an MRI, but immediately a surgical exploration. Most of the patients were females. An average age was 32 years old. It were mostly young patients. And they found something similar. In 85% of the patients, they found a discrete small cyst that arose from the dorsal scapholunate ligament. They sent fibers. Interestingly, they noted that the most distal millimeters of the ligament were normal. So it seems to be a problem at the more proximal side of the dorsal scapholunate ligament. So the occult dorsal wrist ganglion is the most common case of dorsal wrist pain in athletes. Clinically, you will find an elective pain at the level of the dorsal ligament that's 1 centimeter distal of listed tubercle. Often wrist motion is limited and pain can be provoked more by doing a hyperextension, but sometimes also when you put the wrist of the patient in wrist hyperflexion. Some authors believe that the occult ganglia can be more painful than the visible large ganglia. What can we do for treatment for these patients? Conservative treatment has been described, and I found an interesting article this year of a group that applies the carpal stabilizing tape. So it is not an elastic, but a really rigid tape that is applied around the wrist. And you have to see that you include 4 trigger points. One is the dorsal ridge of the scaphoid, the other one is the tubercle of the scaphoid. And then you have to also include the triquetrum and the pisiform. And by stabilizing the proximal row like this, in their series, they have an experience that it can really relieve the pain and increase the motion of the wrist again. Surgically, the system can do this open. You see the intraoperative picture of a small blinking cyst, and it has been advised after resection of the cyst to coagulate the dorsal scapholunate ligament. It can also be performed arthroscopically. There is no capsular window that has to be left behind. You have to make it large or small. That's not really sure. And the recurrence rate after this procedure is 5%. So you've seen that the occult dorsal wrist ganglion is the most common cause of traumatic dorsal wrist pain, but there have to be excluded some other diagnoses too. Look at the bone. So on a normal X-ray, you can look for an intraosseous ganglion that also starts at the dorsal scapholunate ligament. You can have Kienberg's disease. You can have impingement of the capsule, of the scaphoid bone against the dorsal limb of the radius. But you can also have functional problems and nerve problems, like pain coming from the posterior interosseous nerve. Dorsal wrist capsule impingement has been spoken about by Miriam before my presentation. Here you see some intraoperative pictures. So it's some thickening of the dorsal wrist capsule that is thickened by the repetitive stretching and compression of the capsule. In contrast to the occult dorsal wrist ganglion, this pathology is seen more in males than in females. They have on clinical examination elective pain at the dorsal radiocarpal joint, and you can provoke this pain by doing a wrist hyperextension. MRI in most cases can be negative. Of course, you can sometimes see problems on the MRI, like an occult dorsal wrist ganglion, but this is more than concomitantly with the dorsal capsular impingement. You can try to treat this with an intra-articular cortisone injection, and if it doesn't solve the problem, you can do an open or an arthroscopic debridement of the redundant capsular tissue. Scaphoid infection syndrome can be seen on MRI as a zone of bone marrow edema at the dorsal ridge of the scaphoid, and often in the capsule surrounding this tubercle, you can also see some hypercavitation on the T2 images. PIN syndrome, it's really uncommon. In the earlier publications, they thought that it was a cyst that developed primarily into the nerve at the level of the wrist capsule. But later on, Dr. Spinner developed a theory that it is more an occult dorsal wrist ganglion that gave an extension into the nerve. So the problem is not within the nerve itself primarily, but it's more secondary to an occult dorsal ganglion. When the MRI is negative and you cannot find any other problems, you have to think about functional causes of the dorsal wrist pain. Typically in gymnasts, the normal range of motion of the wrist is quite limited to 70 degrees concerning the extension, but gymnasts need, when they want to walk on their hands or stand backwards, they have to give an extension of 90 degrees or more. And this can be a problem on itself for some wrists, but also when the muscles in the rest of the upper limb are tight, this can give a compensatory need for hyperextension at the wrist. For example, many gymnasts have an overdeveloped latissimus dorsi muscle, and this can be tested like you see on the picture on the right bottom. And when they cannot extend the shoulders completely and they have to stand backwards, they will need a compensation in the wrist for hyperextension more than 90 degrees. And this can then be the cause of dorsal wrist pain. So then you have to work and stretch all the muscles so the wrist can be relieved when they do their sports. To conclude, dorsal wrist pain in athletes is typical with wrist hyperextension motions. X-rays are often normal. The most common cause of pain is the dorsal wrist ganglion, and this can be seen on MRI. Always think also about concomitant pathology like a dorsal impingement of the capsule, dorsal scaphoid impingement. Lesions of the interosseous posterior nerve are really rare, and also look at the whole upper limb for tightness in other muscle groups. Thank you.
Thank you, Joris, for this clear presentation with some beautiful insights in occult lesions, very important. We go over to the next speaker. I'm glad to introduce Bart van Eekhout, representing Actor, an orthopedic orthesis company. Next to surgery and physiotherapy, as a surgeon, orthesis, bracing and taping can be very important in our daily practice. So we are curious to hear the talk about sports bracing options for hands and wrists.
Okay, good evening, everyone. Thanks for the introduction. So my name is Bart van Eekhout. I'm the R&D manager for Actor. So first of all, let me explain you who is Actor and what we do very briefly. We are an orthotic and prosthetic company with the goal to allow people with mobility issues to regain their freedom as soon as possible. As Actor, we have a strong technology-driven approach, not only in the end solution, but also in the process how to get there. I hope you will see this further on in this presentation. Some figures, Actor have an annual turnover in 2019 of 90.5 million euros. We work with 105 employees. Our core activity is based in 5 groups of the reimbursement, namely prosthetics, orthotics, mobility soft goods, and shoes. We have 3 sites, one in Oostakker, one in Heel, and one in Jamblu. And of the goods we provide to our clients, 40% is manufactured by Actor, so it is an own production. Today I'll give you some information, some insights in bracing for hand and wrist injuries by athletes. So bracing can be very interesting for athletes to be able to train again as quickly as possible in case of injuries or overuse, while hand and wrist injuries are very common. Some athletes never seek treatment. Unfortunately, delaying the diagnosis and treatment may result in long-term problems or even permanent disability. By adding braces to the treatment, or wrist injury has a minimal impact on the athlete's condition, and the athlete can be resume his or her sports as soon as possible. So an injury can be caused by wrong maneuver, by hard fall, or by overuse. So increased joint stabilization is one of the immediately noticeable benefits of the reduced movement. The less the joint can move, the more likely it is to stay in one configuration and avoid irritating or aggravation the injury. This may cause some temporary reduced range of motion, but of course this will help the recovery. If necessary, some brace can be provided with special hinges that control the range of motion of a joint. This enables the healthcare provider or doctor to set up a progressive treatment by upscaling the range of motion in the treated joint. So when recovering from an injury, an ergonomic brace may provide a degree of protection for external influence. While it may restrict the degree of movement, it also offers a protective layer for the injury, thus contributing to the healing. Those who wearing a brace recover from surgery may also find this protection as highly appreciated. It must be noted that while braces may limit movement by design, some models actually permit movement in some specific joints. This may vary according to the brace or splint used, and of course depend on the nature of the injury. However, most users generally find that their day-to-day activities are less hindered by the brace than they expect. So for bracing, we define 3 groups of solution. The first ones are the prefabricated braces, the prefab. There is a lot of different models and variants and different qualities. Therefore, you need to have a large stock to ensure you have the right model for the right patient indication or activity. Also a good fitting, reduction of movement, and not existing functions for certain treatments are common issues with prefabricated braces. The biggest benefit of the prefab brace is that they are immediately available. They contain out of several standard sizes to achieve the best fit. The second group we see as the immediate fitting brace, EMF. These braces are an alternative for plaster casts. They exist out of a thermoformable plastic that need to be heated in a hot water bin or that should be heated in a low temperature oven. They are tailor-made, also immediately available and very user-friendly and hygienic. EMF braces are perfectly compatible with the RX scan, so if you need to take an RX scan, an EMF brace is suitable for that. EMF is just a temporary solution, and the durability of these braces is not very good. So the last group of braces are the custom-made braces. Custom-made brace is fully tailor-made, so it has the perfect fit for the patient, and it can also be personalized. In terms of design, support, materials, and functions, nearly everything is possible. This enables us to design braces who can be rigid and flexible at once. Braces with add-ons to support specific sport activities, but also braces with a maximum optimized material use, lightweight braces, everything is possible. The trim lines or outlines of the brace can be designed in a way that a joint may be support or fixed maximal, while the rest of the hand is free in movement. So there is no side limitations in movement during recovery. The materials that we use are also very durable and have a long lifespan. Of course, it takes some time to produce these braces. They are not off the shelf if you compare it with the prefabricated braces. So the first process I will explain is the conventional way of working for custom-made braces. For custom-made braces, we start from a scan to capture the limb. Once we have the 3D model of the patient, this will process through our ERP system and finally be rectified by a certified technician. After the rectification, we will send the model to a robot who will melt the 3D model out of a polyurethane foam block. The next step is creating the brace by thermoforming. All functionalities will be added to the brace, such as the hinges, closing systems, supports, etc. Finally, the brace will be finished by adding some padding, some soft material, and a CPO will deliver the brace at the patient. So this was the conventional process, which take still a lot of time. To reduce the lead time and increase the accuracy, material capabilities, and functionalities, nowadays the braces are printed by 3D printer. The process of measuring and rectification is the same as in the conventional way. So when we have to rectify a model, we put the 3D model. When we rectified the model, we put the 3D model into our customizer, who will fit the 3D scan onto the pre-designed library model. When the rectified 3D scan and the library model are morphed, so a matter of fact, put it together, this file will be sent to a 3D printer that will print the brace fully customized and tailor-made to the patient. So, a matter of fact, 3D printing has a lot of benefits. So we achieve the perfect fit for the patient and obtain a maximum degree of freedom. The braces are light and very easy in use and easy to clean. We can support actually exactly the joint or the part of the hand or wrist that we want, while the rest of the hand is free in movement. Material optimizations and integration of functional parts is a piece of cake. It's possible to personalize also the brace with the name of the patient, the name of the service, or even the name of the doctor, or the logo of the doctor, whatever we want. So to optimize the production process and to speed up the design process for the braces, Actor developed together with a software partner our own 3D customizer. The software makes it possible to design different library models as requested by doctors or related to certain pathologies. Due to software, Actor can very fast develop new products in consultation with doctors or the medical staff. So in short terms, the software enables us to set up a decentralized production approach, so we can reduce the time to patient tremendous. In the future, we don't produce the braces in our company, we will produce them in the hospitals directly. So the software is basically developed to use in combination with 3D printing, but in the future it will be also possible to use every CAM machine we want. So for example, laser cutters, 3D knitting machines, and stuff like that. So how does the software work? So once we designed the library model in consultation with the doctor or the medical staff, we open the front end of the Actor 3D customizer and we upload the rectified model, so the rectified 3D scan of the limb. The second step is to position the library model on the 3D scan. The software will morph the library model on the 3D scan and align the add parts, such as a closing system, onto the brace, as you can see on the image. And all of this is done in less than 1 minute. If we do this now manually, it takes 3 to 4 hours. This can be very quick. And the last step is to select or deselect some additional features, such as a bike support or a ski support. We can also add some patterns to the brace, add the name of the patient or the name of the doctor to the brace. So the next slides show you some possibilities related to sports injuries. The first one is a thumb brace to support the CMC joint. The add-on on the brace enables the biker to grab his steering wheel without the use of his thumb. So it's possible to cycle without any use of force in the thumb. So the thumb can rest and rehabilitate, recover. So the brace has a curved plate, the same curve as the steering wheel. The brace has the perfect fit to the steering wheel and to the hand of the athlete. On the next brace, we added some patterns, as you can see right here. These patterns increase the flexibility of the brace, but the brace still gives the necessary support to the thumb, the CMC joint. By using this brace, the CMC joint has its support as it should be, but it is possible to grab a stick, for example, a golf stick, to play golf. And the last example shows us the same CMC thumb brace. In this example, the thumb brace has a turnable add-on, as you can see on the pictures. The add-on fits perfectly onto the ski stick and clicks the ski stick on the brace. So the ski stick can turn around the pivot point of the add-on. And by wearing this brace, the thumb has a maximal support and enables the patient to have a good grip and fixation on a ski stick. So voila. In this case, the patient is perfectly able to continue skiing with his brace. So I would like to thank you for joining, and I hope I gave you some insights in bracing for sports. Thank you very much.
Arne, can you start the discussion, please?
Certainly. Thank you to all the speakers for their talks, and let's go over to some questions. Maybe first of all, I have a question for Bart van Eekhout. Very interesting to hear about your 3D evolutions that we see in surgery. Believe in, I think, also in your product, but maybe about materials in athletes to prevent the sweating and the smell of the braces. Are there any evolutions to see in the future?
Yeah. One of the biggest advantages in 3D printing is that there are a lot of materials that are developed and will be developed. Especially the medical world is very important for 3D printing materials. So a lot of manufacturers are developing materials specific for certain treatments. So as today we use biocompatible materials, but in the future there will be a lot of new materials that will be developed, and as I already explained, we can print on whatever device we want and whatever material we want. So it depends on the demands and on the requirements for a special treatment that we can choose which material we will use. So yes, there's a lot of going on.
Thank you.
Also, a question, Bart, for you. With 3D printing, what type of materials are possible?
As today we use polyamide 11. It's a nylon, and TPU. It's a polyurethane. But as I already said, we already did some tests, so we have now some patient trials with TPU braces. But in the future, we will actually use a lot of materials, a lot of other materials also. So polyprop, all the materials you can imagine can be used for printing.
Okay, thank you.
I have another question for our colleague Mirjam Opdeen. Would you feel, or do you feel that some gymnasts are prone for these problems? Does it depend their anatomy or frequency of training, kind of training? And can we take that with us for prevention of these lesions?
I think my microphone is open now.
Yes, perfect.
Thank you for the question. I think that's one of the big things that we would like to know, if some people are more prone than others. Of course, the intensity of the training will certainly play a role. But as I said, most of these young children practice at least, well, more than 12 to 15 hours a week. So this is the group that we're talking about. What I did see in some of the older patients, and I'm talking about above 15 or 16, is that some of the guys especially have already an extension deficit in their wrist. And you can imagine that if your normal wrist is not really has the possibility to extend for 90 degrees, you will put even more pressure on it if you try to push on the wrist. So I think that some anatomical differences may predispose to these problems, but we haven't really figured out yet in the younger group if we can identify risk factors for the epiphysitis.
And also a question for Miriam. Do you see this type of gymnast wrist and problems arise more when they tend to get older, that the joints become more stiff? Is there a certain age, and when you get older than that age, it is almost impossible to do gymnastics because of problems with the wrist? Or is it just a matter of training and rehabilitation?
Well, I think it's a matter of training, and I think there's a little shift in the age group. If you have the younger children, you will see more of the problems at the epiphysis, and then in the older ones where the epiphysis is closed, we see more of these problems of the joint capsule being impinged in the wrist joint. And that's why we developed, or I didn't develop it, but some of the people in Holland developed these splints to actually allow people to support on the wrist without having really that 90 degree of extension. So I think there's a little bit of a shift in the diagnosis between the younger group and the older group. I don't think that at a certain age you won't get these problems anymore. And I don't think that some people that have these problems cannot get to an elite level. I think you can still get to an elite level even if you don't have that full extension. And for boys, it's a little bit more easy than for girls. And you can understand that because they have different different exercises that they do in the competitions. And they have more exercises where they have an extended wrist and they push on the extended wrist instead of having these exercises with a fully extended wrist. Does that answer your question, Joris, or did I misunderstand it?
Thank you. I have a second question. It's when it's typically said that in gymnasts they have a higher risk of closure of part of the distal radius growth cartilage with deformities at the distal radius. Did you really see that in your group and in your research, or is it more caused by like the Vickers ligament, by anatomical problems at the wrist itself?
No, we do see early closure of the epiphysis in the distal radius, and it causes not so much growth disturbances in the radius, but more even overgrowth or relative overgrowth of the ulna, because the closure of the epiphysis is mostly in the radius, as it translates most of the force. And what you can see if you have early closure of the epiphysis of the radius at the age of 10, 11, 12, you can have a relative overgrowth of the ulna, and they come later with a ulna plus variance that is probably due to this early closure. And that's exactly what we want to prevent when we see this widening of the epiphysis, and that's why we give them a cast.
Okay, interesting. Thank you.
Joris, one question for you too. I'm also very aware of this occult ganglion cysts, and I always search for them. My question is, how low is your threshold for surgery? Does it depend about the pain or resistance to conservative treatment?
First of all, when I can confirm the diagnosis on the MRI, I suggest to the patient to give a really well localized infiltration with cortisone, and then I see the back after 2 to 3 months. If that doesn't resolve the pain, I let the patient decide if they want to go further with surgery or not. It just depends on the pain. And it's important then to remove the dorsal wrist ganglion, but I do the procedure open. And then I do a coagulation with bipolar cautery of the dorsal scapholunate ligament. And that seems to solve the problem. But I know, Arne, you have a lot of experience with arthroscopy. What do you do instead of the coagulation, or do you also coagulate with the arthroscopy?
No, I do mostly arthroscopy. I try to prevent this coagulation. Always a bit afraid about this end branch of the nerve. But I think it's important what you said about the volume. It's not the big ones who are who give problems. So I think it's always important to search for them and treat also the little occult cysts. But of course, it depends on the treatment, conservative treatment first of all.
Okay.
Anna, can I ask a question to Joris?
Of course.
Joris, I was wondering about the tape that you showed us around the wrist and the trigger points, because I know that in the past we've also seen on the market these tapes for carpal tunnel syndrome, and I've always wondered, because the skin is so much more supple than the ligaments and the structures below, I couldn't really understand why they would have an effect, and I wonder what you really think about these trigger point that you push in that tape, and what the effect is.
I just discovered this treatment when preparing this presentation, so I'm still wanting to use and try it. According to the article, because it's a recent article that I mentioned, it's a recent technique, and I think it works by compressing the proximal carpal row. When you look where the trigger points are, and I think they want to avoid the division of scaphoid and lunate with extension, and to keep the scaphoid and lunate more together, and like that prevent like an overuse of the dorsal scapholunate ligament and following a mucus degeneration. I think that's the way they suppose it works, but I should try it. I don't have any experience.
You think it's tight enough? Because
yeah, you need a really tight tape. That's a prerequisite. So it cannot be subtle. It's a really tight tape. That's what they describe. Okay. Indeed. So you really have to compress it around the wrist, and it cannot be elastic at all.
I hope you will publish your results, Joris, in the near future.
Okay, I will let you know. Thank you.
So thank you all for the comments. I don't see any other question. I think we can close this part of the session, and let's introduce the second part.
Dr. Verstegen works as a hand and wrist surgeon in the Monica Hospital and the University Hospital of Antwerp. He is a board member of the Belgian Hand Group. He's also active in the European Federation of Hand Surgery Society. He has a lot of experience in treating world-class tennis players and athletes. And today he's going to share with us his experience in undersided wrist pain in tennis players. Frederik, it's up to you.
Okay, thank you, Joris. I'm very happy to be in this session on sports injuries and talk about tennis injury-specific injuries in tennis players. As you know, and most people are aware of this, that we see a lot of ulnar-sided wrist pain in tennis players, and that has to do with the complex anatomy and biomechanics and movements that we make in the wrist, and secondarily because of the high load on the wrist during tennis activities, not only in professional players, but also in recreational tennis players. And this can really be problematic for players, because with ulnar-sided wrist pain, they will have either no fun playing, or they will not be able to play if they're professional players. And it's also problematic for us as surgeons, because there is a lot of things that can go wrong on the ulnar side of the wrist. And it's not uncommon to see patients who've had 3-4 surgeries for ulnar-sided wrist pain without really solving the problem. So if there is one thing that I've learned over the last 20 years, and I'm very happy that Miriam Obdan already mentioned this, I think if you can localize the pain, especially on the ulnar side, if you can localize the pain, very often you will have the diagnosis that can then be confirmed by more imaging and so on. Now, I have 10 minutes, which is not enough to talk all these things, but I will focus specifically on injuries that are really seen very often in tennis players, which is the ulnar impaction syndrome, which is ulnar styloid impingement, and ECU tenosynovitis. Now, you're familiar with ulnar impaction syndrome. It's probably the most common cause of ulnar-sided wrist pain in a general population. Patients will have chronic activity-related pain at the ulnar carpal joint on palpation, and when you bring the wrist in some extension and ulnar deviation and then pro-insupinating, very often that will reproduce the pain. And this is a common injury in a general population as well, not only in tennis players. So why do we see it more often in tennis players? Because one of the reasons is that the load on the ulnar side of the wrist is very high. Now, this is traditional teaching, about 20% going through the ulnar carpal joint, and this is more recent in vitro testing of loading of the wrist. And it's a busy slide, but if you look at the forces that go through the ulnar compartment with the wrist in supination and ulnar deviation, you see it's about 65% of forces that go through the ulnar carpal joint. And that's exactly the position of the wrist at impact in the ball, very often in a forehand stroke, ulnar deviation and extension of the wrist. So it comes no surprise that high load will cause problems on the side of the wrist. It's not just pure compression, there is also a shearing factor. And every time we pro-insupinate, the TFCC and the carpus are shearing over the distal ulna, which can cause further damage and cause these central TFCC lesions that we see so often. Now, this is an X-ray, and you don't need to be a hand surgeon to see that this patient has a problem, ulnar impaction, and he's gonna probably need further treatment. But it can be more subtle, and that's what we see in tennis players, and I think it's almost specific for tennis players. This is an X-ray of a patient with a clinical examination that is very suggestive of ulnar carpal impingement. You see slight changes on the lunate, but enough distance here, and it would not really worry you, this X-ray. But then if you look at the arthro CT scan, and I think arthro CT scans are the best examination to confirm the diagnosis, you see all the signs of chronic ulnar impaction. There is a central tear in the TFCC, there is cartilage damage over the ulnar part of the lunate, and there is a LT tear here at the joint. So this is chronic ulnar impaction with very limited changes on the X-ray. And that's something we almost exclusively see, I think, in patients who load the ulnar part of the wrist a lot, and that's specific also for tennis players. You don't need to have a TFCC injury, you don't need to have a marked positive ulnar variance to have ulnar impaction syndrome if you load the wrist very highly. And this is a tennis player. He has a completely intact TFCC, but he has signs of impaction. He has lost cartilage on the ulnar side of the lunate, and he has a cyst. So this is really problematic for him, and it would show very little on traditional X-rays. The treatment for this, and if you have an elderly patient with abutment, those can be treated with arthroscopic wafer procedures if they have a big TFCC tear. But I think that's a minority of the patients, and I limit this treatment only to very severe cases, elderly population with positive ulnar variance. That's maybe the recreational tennis player, but that's not a professional tennis player. And I would never do this procedure in a professional tennis player. So what is my preferred solution? It's a ulnar shortening osteotomy, and we have a way too short time to go over the details, but I think this can be a very successful procedure with 100% union rate if you stick to some of the details. And I'll skip this because it's gonna last too long. Now, you need to have something in a differential diagnosis, and that is ulnar styloid impingement. It's also something I almost exclusively see in tennis players, which is impaction of the ulnar styloid on the triquetrum when the wrist is in maximum extension and supination, as you can see on the cadaver simulation here. What is the position of the wrist in a two-handed backhand at the moment of impact with the ball? it is maximum extension and supination very often. So if players have pain at impact interval when they play a two-handed backhand, you need to exclude this diagnosis. Again, it is a very easy test to test this. You bring the wrist in extension, then you rotate to test the wrist in supination. And when there is impingement, you will see they have pain at maximum supination, no pain at extension, or no pain when you reduce supination. So this is almost pathognomonic, I think, for ulnar styloid impingement. It's a clinical diagnosis that is then confirmed on imaging, and this is a MRI of the same patient, and you can clearly see degenerative change at the tip of the ulnar styloid, cyst formation, and changes at the triquetrum. This is a very nice image. It's not always as clear as this, but very often you will see some changes on MRI. And the treatment, if conservative treatment fails, and we'll always treat these with at least one steroid injection before going to surgery. But then the treatment for this is resection of the ulnar styloid, and it will solve the impingement. There is a third lesion that's almost exclusive in tennis players, and that's instability of the extensor carpi ulnaris tendon. Instability that occurs when the wrist is brought into slight flexion, ulnar deviation, and supination, which is the movement that the wrist makes during a two-handed backhand stroke. So almost always I see these injuries in a two-handed backhand player on the non-dominant wrist. And very often, if they have ECU instability, they will remember when it happened. There is a sudden crack of the ECU subsheet, and since then there is instability and pain. You know the anatomy of the wrist. There is the extensor retinaculum, which makes the 5 compartments, and then goes as a sling around the ulna, as you can see here in the cadaver. And it's very important because this sling slides over the ulna, and you need to have this sliding movement of the sling over the ulna, or you will lose pro and supination. So whatever surgery you do in this area, you don't want this to scar onto the ulna, because you will lose pro and supination. That's important when treating these ulnar-sided problems. Okay, and then you know the ECU has its own ECU subsheet, and it's that subsheet that is torn when you have ECU instability. We're doing this in a cadaver. We cut the ECU subsheet. As long as you bring the wrist in pro and supination, the tendon will usually stay in its position on the ulna. But then if you bring the wrist in ulnar deviation, supination, and flexion, it will dislocate out of this position. And you understand that if this happens in a tennis player every time he plays a backhand stroke, this is not going to work. The treatment, and these have been classified by Inoue into A, B, and C lesions. I think A and B lesions are very similar. C lesions are avulsions of the subsheet of the ulna. A and B lesions are clear ruptures of the sheet, and the treatment is different. And you can very often only see what kind of injury it is when you're doing surgery. This is very difficult to distinguish these different lesions with ultrasound or even advanced MRI imaging. So it's usually during the surgery that we see what kind of lesion it is and what the treatment is going to be. And if there is a type A or a type B lesion, you can see here there is a dislocating ECU tendon. Very often tennis players have sort of stretching out of the subsheet, and a primary repair of the ECU subsheet can be possible. This is not like a pulley injury in a climber or something. This ECU subsheet is often stretched out, and you can, let's say 30 to 40% of cases, you can repair it without undue stress on the tendon. As you can see here, this is a simple repair and stabilization of the ECU subsheet. What if you cannot repair it? If you cannot repair it, you need to use a graft, and usually we'll take this graft from the extensor retinaculum, more on the radial side. You cannot use the so-called Spinner-Kaplan sling procedure, because it makes a connection between ulna and radius. And if you make a connection between ulna and radius, the patient will lose pronation. So you need to pay, what we do is we repair the ECU subsheet with a free graft of retinaculum, and that's been working in my patients. There's the other injury is the type C lesion, and you open the extensor retinaculum, you see the subsheet, and then the ideal instrument is a cautery, because you go in the 6th compartment, you don't open it because there is no rupture, so it's closed, and you can palpate it, and you'll find that there is an avulsion of the subsheet of the ulna. and that's the pocket where the tendon will dislocate in. And here is the similar case on the right. Now these are much easier to treat because if you're sure that the tendon is okay and the floor of the ECU subsheet is okay, these can be treated by simple reattachment of the subsheet on the ulnar side of the sixth compartment. You don't need to open the sixth compartment in these patients. And finally, the last thing, the ECU tendon is the Achilles tendon for tennis players. So you have to be very, very careful with steroid injections for ECU injuries. And I've seen at least 3 players who've had a complete rupture of the ECU tendon because of more than one cortisone injection. Okay, I thank you for your attention. I'm happy to answer any questions.
Thank you, Frederik, for this very informative and illustrative presentation. I learned a lot. Now I am happy to introduce the next speaker. It's Dr. Arnold Kramer, who is an orthopedic surgeon specialized in hand and wrist surgery. He works in the hospital in Ulnaris. He's an avid cyclist himself. So I'm really curious to hear his presentation about hand and wrist problems in cyclists. Arne, it's up to you.
Thank you, Joris, for this nice introduction. Dear colleagues, dear all, I want to speak about some crashes and overuse problems in cyclists. Small part about these crashes, of course, very well known, the different and frequent fractures around the hand and wrists. Scaphoid fractures, metacarpal, phalangeal fractures, and ligamentous lesions on the scapholunate or TFCC are really known in recreational or professional cyclists. But I want to focus on one specific lesion, the hamate hook fracture. It's not that frequent, it's 1 in 3 displaced, and most of the time there's a direct blow injury in racket sports or with a fall in cyclism. There has to be a high index of suspicion. It gives a tenderness specifically on the hypotenar side of the hand, and some specific radiographic exams have to be done. The threshold to do some more investigations is also important with a CT scan or, if necessary, an MRI. Of course, we all know that the normal treatments, certainly in undisplaced fractures for the hamate hook lesion, is conservative. Till 90% non-union is described, but clinically non-relevant. If we speak about operations, we know the open treatment with excision, certainly in delayed diagnose or non-union. But the problem is the same for open reduction and internal fixation. In some cases, we have a difficult, painful palmar scar, certainly in athletes and cyclists. I present you a case, 28 years old, a professional cyclist. He had already an earlier fracture on the scaphoid, but he presented with a non-displaced hamate hook fracture. But he was 3 weeks before the Holy Week in Belgium. Ronde van Vlaanderen, Gent-Wevelgem, Paris-Roubaix. So he asked what to do and for a quick recovery. I searched a bit in literature and I found this article by the group of Oliver Schäufler in Berlin with a percutaneous technique and a compression screw, a bit similar like the Voller approach for a scaphoid fracture. It's a reproducible technique, and we did this treatment in this patient. In his review, he presented 100% union rate in 8 patients. This is the CT scan of the same patient I presented in the beginning, 6 months postoperatively. He doesn't have any complaints anymore, and I can say he changed from a professional cyclist now to a professional boxer without any complaints. So a reproducible technique that we have to keep in mind in treating these patients. Then I would like to emphasize specifically on the overuse problems and certainly the nerve problems in cyclists. We all know the carpal tunnel problems. Of course, this is depending of the aged people who has a lot of problems with this median nerve, but also the position of the hand, and certainly in between cyclism and mountain biking, already the position on the bike is very important. If you see that 1.5 degrees downslope of the saddle already limits and gives problem to the nerve, the median nerve, of course, Tony Martin is an example as a former world champion in time trial of a perfect position on the bike. But we also have to think about these different positions, or you put your hands on the shifters or on top or in the bars. That can be very different for the stretch on the median nerve. Therefore, the recent upcoming bikes, Pedelecs and other electric supported bikes have this butterfly support for more spread pressure and changing position for a better comfortable posture of your biker. Also, alternative hooks on the end of the handlebar, like seen over here or in the middle, can help for an alternative position. When we speak about cyclist palsy, it's especially mentioned for the ulnar nerve problem at the canal of Guyon. And that's not that frequent, but a very difficult problem if it gives you some motor deficit. Again, the position of the hand is prone for this problem because there's a lot of pressure on the ulnar side of the nerve. And if you look a bit in literature, we see a specific evolution in mountain biking from the 26 wheels to the 29, the bigger 29 wheels the last decade. And all of them have a very wide handlebar. That is because of more control, easier breathing, and a better positioning for balance. But if you look at the back sweep in these handlebars, if we look at the position and certainly the more internal rotation of some drop bars, we see that there's much more ulnar abduction in the wrist and the hand, with more pressure on the ulnar compartment. Also, the width of the handlebar gives you much more pressure on the ulnar compartment. And it's obvious if you look at these mountain bikers that they lock their elbow in extension. Again, a more extended and ulnar abducted position of the wrists. So things to think about. Of course, we can find some tools to diminish the shock and pressure absorption as these butterfly types. Also adapted gloves, of course, and extra taping on the handlebar. A more recent evolution in cycling are these gravel bikes. Canyon presented a beautiful of these gravel bikes example, but with a very specific handlebar. If you check this, it's called the Hoover bar. Why? Why is that interesting? Again, for long distance, for a better upright riding position, to improve the position front end, and with the thumb extra support. So maximal shock absorption in this case. To finish, one little remark about another less frequent lesion, but here in two professional cyclists, intima hyperplasia of the ulnar artery and an aneurysma of the ulnar artery. Also here to keep in mind, the hypotenar hammer syndrome. As a take-home message, it's always important for bikers to have a comfortable, relaxed position on the bike. Every moment of the ride, there should be possible to have the possibility to jump over something. Think about the small, correct handlebars, not too wide. Think about using tools and other tips and tricks, of course, when there are any problems. And prevention before treatment, of course, because we all know if there is already a motor deficit of the ulnar nerve at the canal of Guyon, this gives very difficult problems and a difficult rehabilitation. Cervical origin is very rare for these problems. I would like to thank specifically Mr. Michiel Delvat, experienced osteopath, professional bike fitter, renowned mentor of professional cyclists and triathletes in Menen, who shared his experience the last years with me, also arranging my own bikes. And I would like to thank Dr. Jan Noyer as president of the BVOT, as organizer of this Congress, and as also personal mentor for me, not only professionally. Thank you very much.
Thank you, Arne, for this very interesting and practical presentation. And I think I have to refit my bike the next time before I will take it on the road. The next speaker is Dr. Mathieu Marois. He's an expert in physical medicine and rehabilitation in the same hospital as Dr. de Kramer in AZ Delta in Roeselare. And he's involved in the conservative treatment of high-level athletes. So, and he's going to present us his experience with compartment syndrome of the arm in sportsmen. Mathieu, it's up to you.
Thank you for the nice introduction. As Arne was a habit cyclist, I'm more a habit padel player, so I'm more involved in pain problems, was also very frequent in racket sports. This problem is next to that kind of sports, also in rock climbers, wheelchair athletes, but also musicians like violin, piano players, manual workers as carpenters. But everyone knows it's the biggest problem the motocross racers have to deal with. It's very frequent bilateral. More than 90% of the problems is on both sides, because the forearms, during a motocross race of 20 minutes, the forearms are exposed to continuously motor vibrations, and while balancing on the rough tracks, the muscle is continuously in action. A muscle group who is in action increases 20% in muscle size and volume. This is because of the muscular blood volume and the hypertrophy and the edema. And when there is an incompliant fascia, a too stiff fascia, then the pressure rises up to pain comes up. Rising of the pressure stands with accumulation of lactic acid. When the sports activity continues, the pain gets more and more, and at one moment the sportsman has to stop his activity. As you can see, at rest there is no pain. The pain is progressive during exercise, and after stopping the exercise, normally a motocross race is around 20 minutes, the pain is self-limiting, resolves almost completely. But when the pain comes up, sometimes after some minutes, the performance can be very, very bad, and they look for a solution. Mostly they tell you the specific itching pain, the burning pain. If it's very intense, there are paresthesias, there is altered sensations and a loss of grip strength. So when they can very well tell you the specific symptoms, diagnosis is quite clear. But not every sportsman, not every patient, as you know, can exactly tell you what's the problem. So clinical examination is very frequently also necessary. At rest, there are no problems. At your office, you have to do provocative exercises as a 50-minute hand grip test till exhaustion. And then the patient will tell, that's the feeling I have while doing sports. And then the diagnosis is made. When this is not very clearly the case, in the upper arm, it's often very, very clear. In the lower leg, it's different. But sometimes you have to think about the other possible problems. But the type of patient who sits in front of you, the type of sports he's doing, helps you to go the right way. On your left side, you can see a little bit the musculotendular problems. When there is tendinopathy, normally they will have pain at start, and during exercise, the pain will get less. In compartment syndrome, at start there is no pain, and after some minutes, the pain is progressing. How can we confirm diagnosis? There are two ways of doing that: an intracompartmental pressure monitoring and MRI before and after exercise. In the lower leg, we have the criteria of Pedowitz since the 1990, where the resting pressure cannot be more than 15 millimeter mercury after 1 minute and 5 minutes, respectively 30 and 20 millimeters. We use them also in the upper leg, but we are not sure if we can use them. Some authors postulate that in the forearm, we have to deal with lower pressures. So maybe from 10 millimeters, it's already positive. Some say that maybe a rise of 10 millimeters with exertion is already a confirmation of diagnosis, or the resting to normal resting pressure after exertion. If that takes longer than 15 minutes, then we also can confirm diagnosis. Everybody knows on the right side, on the upside, the striker device, which was used long time with the heavy needle, let's say. But since 1 or 2 years, this striker doesn't provide this anymore, so it gives us a problem. We are using for the moment this device, very easy in use. The needle is a little bit smaller, so that's better for the patient, but unfortunately it's 4 times more expensive for the patient. Normally from next year on, we will again have this device, because an American company will be approved in Europe, but we are still waiting for that. Because of this logistic problems, last year's MRI is more and more used in diagnosing this problem. MRI, we have to do it before and after exercise. On your left side, we can see a normal MRI scan at rest, where you have the iso intensity of the muscle compartments and where you can well see the intramuscular vessels. After exercise, we can see on the T2 weighted images hyperintensity here in the flexor compartment, the extensor compartments, and here you can see we can't see the small vessels anymore. They disappeared. So that's a little bit the pathognomonic sign for a positive MRI from compartment syndrome. The sportsman who's sitting in front of you, he wants a solution. As I am a specialist in physical medicine, we try to resolve problems conservatively. And all these things you can see here have a role in management of exercise-induced pain. But the sportsman sitting in front of you, he wants a solution, and we can't give him. The only thing we can say, that's your problem, and if you want to solve it, or you stop your hobby, you stop your sports, or we have to go for surgery. Since 20 years, since the 80s, surgery has been done. In the beginning, surgery was with very widely incisions, like they used in acute compartment syndromes. But year by year, we could see that more minimal incisions have the same results. Results have very good results. That's why when we think only the muscle bellies expand, the muscle bellies are especially in the proximal 2/3. So the lesser the incision, the faster the return, lesser scar, lesser problems. And we could see that we had the same results. We could also do more than an incision, more than a fasciotomy. We can do a fasciectomy, but literature says that, okay, this is only the case when there is recidive after a first operation. And in all the cases since 20 or 30 years, that is very infrequent. As we can see here, the lesser the scar, the faster return to play, the same results. The lesser the scar, the lesser damage to the subcutaneous nerve. But if the approach is quite small, the bigger neurovascular vessel of structures can be lesions. And with a new described endoscopic technique in recent years, this is a study of Jans and his colleagues some years ago in 2015, in which they used an endoscope, which is frequently used in vascular surgery. They had an approach distal at almost at the wrist, and with this approach, they have a broad view on several structures. So the problems of nerve and vascular lesions you can avoid by this, and they can make the fasciotomy up to the elbow. So very good results, small incision and fast return to play. And that's what the sportsman who's sitting in front of you is asking for. When we can conclude here, the history is a lot of times very clear. Clinical examination can confirm as to the compartment pressure measurements or MRI before and after exercise. And if the sportsman wants to continue with his sports activity, surgery has to be done. A widely incision, smaller incisions, endoscopically, they have the same results. And as we can see, the faster return to play and a good safety, the smaller the incision, the better. Thank you.
Arne and Friedrich, it's up to you. You can start the discussion.
I'm looking for some questions. Okay, so Arne, I have a question for you. In your experience with cyclists, do you think carpal tunnel syndrome is more prevalent in mountain bikers or in road cyclists?
I think carpal tunnel syndrome is much more frequent in cyclists, but I think it's just more frequent also, and it's more frequent in aged people. But I think in mountain biking you have more different positions and you don't see it that much. It was just for me a bit specific, and recently I found some patients with this problem of the ulnar nerve, and that was a bit the suggestion with the problems on the mountain bike. So that was more an ulnar problem on the mountain bike.
And often I see older patients that are sitting more upright on the bicycle, so they don't put a lot of pressure on the hand, but they complain about carpal tunnel syndrome when cycling. Do you think there that a specialized glove would alleviate the symptoms?
Yeah, I think all these things I spoke about was just in patients who have problems or cyclists who have problems, of course. But then you have to search for some position, bike fitting, the gloves are for sure important. So you see that these patients or more aged people search for a better position. And then I think you can prevent the carpal tunnel problems, of course, depending of their evolution, of the evolution of the carpal tunnel in the future in their daily life, of course.
Okay, thank you. Also a question for Frederik in tennis players. What is your top 3 of differential diagnosis when you have a tennis player when that has undersided wrist pain? What's your top 3 in the order of incidents that you think about and that you want to rule out?
Okay, thank you, Joris. The most common problem definitely is ulnar impaction. And the second, I think, and that's the ECU problems. And but the ECU problems are really something that we always see in professional or semi-professional, very high-level players. It's something I rarely see in recreational players. So the ulnar impaction, that's something you rarely see in high-level players because they don't get to the high level with ulnar impaction. They should have probably very often is diagnosed much earlier in their career. So that's something you see in 50, 60-year-old recreational tennis players, quite common. And then the ECU problems is really in younger players or in highly level athletes. And then there's all the others. I think I don't have to tell you, there's about 20 different things that can go wrong on the ulnar side of the wrist, and it's always a challenge to find the right diagnosis. And when I started 20 years ago, I found it almost impossible to find the right diagnosis. And I think now, by having seen many of these injuries and by probably becoming a better hand surgeon and becoming a better examiner, clinical examiner, I find that it becomes relatively easy to find a diagnosis. And it's been said by some of the speakers already today. First of all, the history is important, then the examination. And if you can localize the pain, then very often you already have a clue of the diagnosis, because at each point of the wrist, there is one thing that can go wrong. And if you find for ulnar impaction, it's typically there, and ulnar styloid impingement is typically there, and ECU is typically, and if you can localize the pain, then that gives you a good clue of the diagnosis. And then you need to confirm it with the imaging
not the other way around. Don't do not the imaging first and then trying to find diagnosis, because you very often the imaging will show you things that are clinically totally irrelevant in these.
But in your experience, Frederik, the localization of the pain is so important. Is there in your practice a place for localized injections with an anesthetic?
Not so much. I think because you want to localize the pain, and very often there's different areas that are painful. So you need to, what I find much more important is to re-examine the patient. So you examine the patient, you look at the imaging, you re-examine the patient, see if it's consistent, if you can really find the pain at the same spot, and then maybe see them back a week or two later, and then examine them again and see, well, is it still that area that is painful? I sometimes will do localized injections, but I think probably what they do is they numb the sensory branch of the ulnar nerve, and then the whole area. It's very difficult to give them so specific that you're just excluding one diagnosis. No, is that not your experience? I sometimes do it for ECU problems. Then you inject the ICU sheet, yeah, more proximal. So you just inject it into the sheet around the tendon, and then you can re-examine them, because then maybe the idea is it doesn't go to the sensory branch, but it's just in the tendon sheet. And if it's an ICU problem, that should be isolated. That should be better with this injection. But I rarely do it.
Okay, thank you. I've also a question for Mathieu. Mathieu, when there's a compartment syndrome release, what do you recommend as a rehabilitation?
I don't know if you can hear me well. I hope so, because my camera doesn't work. Okay, that's good. Normally the rehabilitation is balancing a little bit between having a good scar, so there is not too fast, because when there is a lot of hematoma afterwards, there is more scar, and more scar means that recidive, there is more chance for recidive. But also you have to avoid stiffness. So normally it's some days some resting, and then they can do some mobilization after 3-4 days for 1 or 2 weeks. And 2 weeks after, they can already start mobilization force training, so that then they can restart sporting at 4 to 6 weeks, depending a little bit on the intensity they do. Normally, it's going faster than a release of the lower leg, where we have to take, especially in the posterior compartment, longer term. Here, it's going faster, but it's a little bit balancing between a scarring and making the mobility as good as possible.
Okay, thank you. Maybe any more questions?
Yeah, comment. I think these are athletes, so they will recover very quickly. I don't see that much problem. They all want to quickly recover, and you see that they feel less pressure on these muscles and muscle groups. I think it all depends a bit of the hematoma postoperatively, and that's of course sometimes difficult for us to avoid. And but I don't have any experience with this endoscopic technique. It's more the Overuse technique from cardiovascular surgery. I don't know, Frederik or Joris, do you have experience with that? I do a mini open technique on proximal and distal side.
Yeah. I do just a proximal incision. I think it's really only important to take the muscular part of the forearm and don't need to release the tendinous part. And I'm familiar with the Overuse, but as I understood it, I think Christoph Jans, who published the paper, they have a large group of patients on motorcyclists. But as I understood it, they stopped using the technique because the instruments were too expensive. They did not cover the price of the surgery, and it was far too expensive. And I think they use an open incision also now, and it's fairly straightforward, no, and it's not very dangerous or big surgery. It's fairly straightforward procedure, I think.
When preparing this talk, I had a big summary of all the case reports. They had a little bit faster return to sport, sometimes 2 weeks. They had a group of more than 100, I think. So the win to recover faster was very little there. I think indeed, as Arne says, we have to deal with sportsmen. I think in the lower leg, maybe the hematoma, because of gravity, because of things like that, is maybe a little bit more. So we need a little bit more, 2 weeks more than the upper leg. But normally it's quite fast recovery.
Okay. Thank you all. Arne, do you know or have any more questions? I don't think from the audience we have more questions in. So thank you all the speakers and the audience for your attention and your presence. I think it was a really interesting session. I learned a lot. I want to thank everyone, and I think we can now close this this session of the Belgian Hand Group.
I just finalize. It's a great meeting indeed. So thanks to all speakers for the presentations. Very entertaining, very interesting, and I do learn a lot as well. So thank you. Thanks to the moderators for keeping us focused. Thanks, Arne, for the nice comments. As well, many thanks to all of you for being with us and to support our meeting by attending these ICLs, these instructional course lectures. And of course, thanks to all sponsors. That's all for now. Don't forget, we still have 2 instructional course lectures, and these are scheduled for January. The first one is on 14th of January and is organized by the Belgian Hip Society. Very interesting, spicy debate. And then the last instructional course lecture is organized by the Belgian Spine Society on 21st of January about endoscopic spinal surgery. Okay, thank you. Take care. Enjoy the rest of your evening.
Thank you.
Thank you. Thanks all. Thank you.
Thank you. Goodbye.